The following podcast is part of a certified educational activity titled Raising the Bar in Hormone Receptor Positive, HER2 Negative Early Breast Cancer. Multidisciplinary strategies for integrating the CDK4 and 6 inhibitors. Access the entire activity and complete the post-test at peerview.com/HYM860. Downloadable slides and practice aids are also available.
Hello, everyone. Welcome to Raising the Bar in HR-positive, HER2-negative early breast cancer, multidisciplinary strategies for integrating the CDK4/6 inhibitors into the care of early breast cancer. We're very pleased to be here with the global audience to discuss new data in HR-positive, HER2-negative early breast cancer that's critically important for our practice. I'm Joyce O'Shaughnessy from Baylor University Medical Center, Texas Oncology, and U.S. Oncology. And I'm joined by Dr. Judy Bowie, who is Chair of Breast and Melanoma Surgical Oncology, Professor of Surgery at the Mayo Clinic College of Medicine. And I'm also joined by Professor Stephen Johnston, Professor of Breast Cancer Medicine at the Royal Marsden Hospital in London. Welcome, Judy and Stephen. Well, why are we here discussing this topic today? 30% of patients are going to be diagnosed with HR-positive, HER2-negative early breast cancer and are at very high risk for recurrence based on clinical and pathologic features. And we have very important new trial results from the Monarch E trial that are practice changing. We have a new FDA approval for adjuvant abemaciclib that includes a requirement for Ki-67 testing. And we also have the issue that de-escalation of axillary surgery, which is increasingly the standard of care, may impact adjuvant therapy options. So, Stephen, what do you think the most important reason we should be talking about this today is?
Well, I think what we face is that for a certain group of ER-positive breast cancer patients, despite everything we give them, including chemotherapy and the most appropriate hormone treatment, we know that there's a group that will still develop early recurrences with a degree of endocrine resistance, and trying to understand and overcome that and apply a new treatment has been the goal for the last 10 or 20 years. Now we have new data that really show we have a new option. So I think it's high time we've had something new for these very high-risk patients.
Thanks. How about you, Judy?
Well, I think from the surgical standpoint, as with many of the developments with breast cancer, it's always very important that all of the disciplines are aware of what's changing in the other fields. And here we have a new indication for a drug that can improve patients' outcomes, but that is very much dependent on identifying nodal positivity and number of positive nodes. And so I think that interaction between surgical oncologists and medical oncologists is going to be critical to ensure that we can provide the right drugs to the right patients.
Thanks so much. I think it's a super important topic we're going to talk about here today. So we're going to talk about how can we harness CDK4/6 inhibition as a component of multimodal therapy to improve outcomes for patients with HR-positive, HER2-negative early breast cancer. And Stephen and I will give some background information, and then the three of us will discuss some cases that I hope will illustrate how we apply these new data to patients in our practice. So I'm going to start off with just a brief background of how do we understand high-risk HR-positive, HER2-negative early breast cancer? Well, one thing that's very clear that we can see here on this timeline as we're looking at the hazard rate of recurrence in the first 10 years here, that there is a group of patients that are at very high risk for recurrence within the first 2 to 3 years of their diagnosis of breast cancer. And this peak of recurrence that we see for stage 1, 2, 3 breast cancer really represents primary endocrine therapy refractory breast cancer. And this is a group that we have not had good tools for in terms of improving their outcome. And you can see in the colored bars down at the bottom, this is the window that the adjuvant CDK4/6 inhibitor trials have attempted to bracket to decrease this risk of recurrence in the primary endocrine therapy refractory population. But how can we identify, how can we know that we might have one of these patients up front who could really benefit from abemaciclib? Well, we can look at standard clinical pathologic features, prognostic predictive gene expression profiles, adaptive phenotypic response to endocrine therapy, and specific molecular alterations. And One of the things we've seen and beautifully illustrated in the soft and text trials with central ascertainment of these very important biomarkers here in premenopausal HR positive, HER2 negative patients, that we know standard clinical pathologic features such as younger age, number of lymph nodes positive, and you see the 4 or more lymph nodes, how quickly those patients recur. They're at risk early on for recurrence. Tumor size over 2 centimeters. And also in the bottom right, we see that a weaker expression of the estrogen receptor really is a high-risk feature for early recurrence. We also see that lower PGR expression increases risk of recurrence, higher grade. And then bottom left, we see sort of a continuous variable, a stair step of increasing Ki-67, definitely increasing the risk for early recurrence of breast cancer. Of course, we're well used to using the 21 gene recurrence score. We see in the middle panel that those patients with a high risk recurrence score have a very high risk of early recurrence. These are primary endocrine therapy refractory patients. We also know, in looking at the 21 gene recurrence score, what determines that high recurrence score, it actually over on the right is really mostly dependent on expression of the estrogen receptor, also on higher proliferation, but the lower the estrogen receptor expression, the higher the risk of recurrence. Again, primary endocrine therapy refractoriness. We know from the ADAPT trial here in node positive patients, 4 or more node positive patients, that the higher 21 gene recurrence score again leads to this high risk of early recurrence from breast cancer. Interestingly, we've seen from the PENELOPE-B trial, where patients received preoperative chemotherapy and had residual disease, that patients that have HR positive, HER2 negative breast cancer, it's a mixture of intrinsic subtyping. And you can see in the panel that the red curve, the blue curve, and the purple curve are luminal B, HER2 enriched, and basal-like in this HR positive, HER2 negative population. And we have a heterogeneity of biology, and these patients have a very high risk for early recurrence. We're not doing intrinsic subtyping as a standard of care in our practice, but this may come over time. And then if we utilize the 80 gene blueprint signature that also looks at intrinsic subtyping, we can see that 13% of HR positive, HER2 negative breast cancer patients are reclassified as basal by the 80 gene signature. And we see that when those patients receive preoperative chemotherapy, 34% of them have a pathologic complete response, compared to only 5.6% of patients who have luminal B breast cancer. So it's very interesting to think that within our HR positive, HER2 negative population, there's a group of patients that have basal-like breast cancer, and they're exquisitely sensitive to chemotherapy. And we're also well aware of the 70 gene signature as a biomarker of response and also prognosis in breast cancer. And the green arrow shows the low risk 70 gene, and the red arrow in the center shows the high risk 70 gene. But the high risk now has been bifurcated into ultra high risk, the top 50%, and into just low risk. And they're distinguished by higher expression of proliferation and DNA repair pathway genes. And when this is added onto analysis of the I-SPY 2 trial, where patients received the standard preoperative weekly paclitaxel followed by AC, then surgery, versus adding on the PARP inhibitor olaparib plus the PD-1 inhibitor durvalumab, the checkpoint inhibitor, followed by AC, followed by surgery, we see very interestingly that on the left in the 70 gene signature high risk group, but the lower end of the high risk, the MP1, we see no improvement in PAF-CR, very low, around 10%, no improvement with the addition of durvalumab and olaparib. But in the high 2 population, we do see an improvement in the PAF-CR rate from about 22% up to 64%. These are very similar that as we would see with triple negative breast cancer. So within the HR positive, HER2 negative population is a group of patients that are exquisitely sensitive to DNA repair agents as well as to checkpoint inhibitors, and have a very aggressive biology that also is primary endocrine therapy refractory. And then Lastly, we can actually utilize a phenotypic adaptive approach and utilize 2 to 3 weeks of preoperative endocrine therapy. Then the patients go to surgery and their Ki-67 is looked at, as well as nodal status, tumor size, to ascertain the PEPI score. And in patients who have the higher PEPI scores, and that's basically not suppressing that Ki-67 down to less than 10%, we can see in the purple curves here on the bottom a very high risk for early recurrence, primary endocrine therapy refractoriness. And this is a huge unmet need that we really need to address to improve the outcome of patients. And then lastly, we do know that there's a lot of work going on to help us from a next generation sequencing standpoint identify a priori those patients that have a very high risk of recurrence with our standard therapies. This is a connectivity map of the luminal breast cancers, and we're beginning to find out which of these molecular alterations increase risk, such as P53 mutations, FGFR amplification, et cetera. So in summary, endocrine therapy resistance is the key feature of these high-risk HR-positive, HER2-negative early breast cancer patients that recur within 5 years. And tumor size, nodal status, and grade impact recurrence risk and improve prognostic accuracy of the gene expression signatures. High proliferation and lower ER increase that risk of recurrence. Luminal-B, HER2-enriched, and basal-like breast cancers are high-risk HR-positive, HER2-negative breast cancers, and failure of preoperative endocrine therapy to suppress Ki-67 predicts for poor outcome with adjuvant endocrine therapy. And then there are multiple genomic alterations in high-risk HR-positive, HER2-negative early breast cancer that converge to influence DNA repair, proliferation, apoptosis, and immunogenicity, and to impact our patients' outcomes. And so that gives us a background then of which are these patients that are at higher risk for that early recurrence that we really need to address with new therapies. And I do want to point out that if you will be able to download and use additional resources, there's a very nice practice aid focused on Ki-67 testing and risk assessment that I think will be helpful to you in your practice. And with that, now it's my pleasure to turn us over to Professor Stephen Johnson, who's going to talk to us about evaluating the current and the new data that we have that we want to apply to our practice.
So thank you very much, Joyce, for that introduction. And I'm very happy to talk really about the level of risk that we have here, and really the implications of new data that we've got from a large trial called Monarch E, trying to improve the outcome for these patients with increased risk. As this particular slide shows here, patients who have hormone-positive breast cancer, the last big development was the introduction of aromatase inhibitors nearly 20 years ago, and it showed a small incremental gain over tamoxifen, which had been the previous standard of care. But as pointed out, in that first 2 to 3 years, patients are still relapsing despite aromatase inhibitors with primary endocrine resistance. And understanding who those patients are and what better options we have for them has been the goal of research over recent years. Now, CDK inhibitors have been evaluated in advanced breast cancer, and we have 3 agents: palbociclib, ribociclib, and abemaciclib, as shown on this slide here. And palbociclib and ribociclib are very similar drugs, which are potent inhibitors, but abemaciclib is a different drug. It has a slightly higher affinity for CDK4 and a broader kinome inhibition spectrum, and is given as a continually dosed drug with GI side effects the main rate limiting factor, whereas palbociclib and ribociclib are given 3 weeks on, 1 week off because of hematological side effects. Now, as we can see here, in advanced disease, these drugs have transformed the outcome when combined to aromatase inhibitors in these trials, PALOMA-2, MONALEESA-2, and Monarch-3, where they are now the standard of care if patients relapse with hormone-positive metastatic breast cancer, because compared to aromatase inhibitors alone, they have substantially improved progression-free survival, and we've now seen some early data with MONALEESA-2 that it also impacts on overall survival. So the question is really, do these have a role in the adjuvant setting in curing more patients? Now, when we're evaluating therapies in early breast cancer, the traditional order of looking at drugs has been to consider them after surgery in an adjuvant setting where we're essentially giving the drugs blind. We have to do large trials comparing the addition of a drug to no addition of the drug and follow patients for a number of years. There is an alternative method of using neoadjuvant therapy, which we use to downstage tumors, sometimes allowing us to convert a mastectomy to breast-conserving surgery. But we also have the opportunity to study drugs over a shorter term exposure and see how it manifests and changes the biology of the disease. And we have an opportunity to measure something called proliferation, measured by the Ki-67, which is an immunohistochemical test of cells in the cell cycle. And this is a model we've used for a number of years to evaluate the impact of, for example, letrozole after a short-term exposure of 2 weeks, where you can see in the bottom graph that Ki-67 for the majority of patients will fall and then remain suppressed over a period of a few months before surgery. But there are a group of patients where the Ki-67 may not fall and remain elevated. And this could be the hallmarks of those primary endocrine resistant tumors that are going to relapse early. So we've integrated proliferation and Ki-67 in particular as a measure of endocrine responsiveness and resistance in a number of studies. And we'll talk about that today. Now, in terms of the neoadjuvant setting, to set the scene before we look at the Monarch E trial, there are a number of trials that have looked at adding these agents to aromatase inhibitors in a short-term exposure before surgery. The Monarch study looked at this with the addition of abemaciclib to anastrozole compared to either anastrozole alone or abemaciclib. And the primary endpoint was the change in Ki-67 at the 2-week point, and then all patients were treated with the combination through to surgery at around 14 weeks. In terms of clinical radiological response, it was around about 46% with the combination. And pathological CR, which we're used to talking about in triple-negative breast cancer or in HER2-positive breast cancer, was really relatively low in endocrine therapy, even with this combination at only 4%. And we'll come back to that. But if you measured what happened to proliferation when you added in abemaciclib to anastrozole or even used abemaciclib on its own, you see much greater drop in Ki-67, as you can see in these individual waterfall plots. And when you look at cell cycle arrest, that tells you how many patients' tumors went into a complete cell cycle arrest, you can see that that improves in 2 weeks from 15% with an endocrine therapy to over 60% when a CDK inhibitor is added. Now, another trial that we are involved with was the PALET trial, which we did in conjunction with the NSABP. And this looked at a different CDK inhibitor, palbociclib, in combination with letrozole, again with a change over 2 weeks. But this trial had the option of letrozole alone as a control arm through to surgery, which provided a reference and a control for what happened at the 14-week time point. In our particular trial, we were interested in the change in Ki-67 through to 14 weeks, as well as the clinical response data. And what you can see here in these individual plots is that when letrozole alone is used, there were a significant number who dropped the Ki-67, but not all of them. And as soon as you added the CDK inhibitor, far more patients had complete suppression of their Ki-67 by the time of surgery. And here, when looking at cell cycle arrest at the 14-week point, as opposed to the 2-week point, you can see that with endocrine therapy alone, it had improved to around about 60% from the 20% at 2 weeks. But with the CDK inhibitor added in, over 90% of the patients were now in cell cycle arrest. But did that translate into any better clinical outcomes in a neoadjuvant setting? Well, the answer is no. The clinical response rates were very similar, and the pathological CR rates remained very low at around 3 or 4%, similar to the other trial. But you're still affecting the biology of the disease. You're affecting proliferation. You're switching it off in a much greater number of tumors, even if you're not completely causing the tumors to shrink and disappear. In this respect, this treatment option is very, very different to chemotherapy, which we've been used to looking at in other subtypes. So what about the adjuvant studies? Well, 2 large adjuvant trials reported out a year ago at ESMO, looking at these 2 particular drugs, palbociclib in the PALACE trial and abemaciclib in the Monarch trial. And these were looking at patients who had certain risk characteristics. And then once they completed their primary surgery, chemotherapy, radiation treatment, and they were onto their adjuvant endocrine therapy, they were randomized to 2 years of the addition of a CDK inhibitor to their endocrine therapy or endocrine treatment alone. Both studies were open label trials, and both used the drug for a period of 2 years to cover that high risk period that Joyce talked about in the introduction. Now, the initial trial, palbociclib, reported first in a press release and then the data at ESMO. It looked in patients with stage 2 and 3 disease. You can see that there were a group of patients had node-negative disease. Around about 80% had prior chemotherapy, either in the neoadjuvant or adjuvant setting, and just under 60% had high-risk features determined by 4 or more nodes, or if 1 to 3 nodes, an additional factor of high grade or large tumor size. Unfortunately, this trial was completely negative, and at a median follow-up of 23.7 months, there was absolutely no difference in 3-year invasive disease-free survival on the left, or distant relapse-free survival, looking at sites of metastatic disease, on the right. So the trial was stopped, and it was a negative study. Now, there are reasons why this might be the case, which we'll come back to shortly. Now, the other trial was the Monarch E trial, and these presented data last year at ESMO, published in JCO, and then Joyce presented these data in an updated form at the ESMO plenary just a few weeks ago. And this now provides much more robust data on the impact of abemaciclib in the adjuvant setting. Now, it's worth looking at a couple of points first. The initial analysis was at a median follow-up of 15 months, which was by many thought to be relatively early, but it was a positive trial at that point. It was triggered by an interim analysis, which met the statistical significance of reducing the risk of invasive disease-free recurrence by around about 25%. But it wasn't known at that stage really what the role of Ki-67 was, and that's new sets of data that were presented at the ESMO plenary recently. So let's look at the trial design in a little bit more detail, because there were 2 cohorts, but all patients were node positive. And the majority of patients were in cohort 1, where they had 4 or more nodes, or if 1 to 3 nodes, they had either grade 3 disease or a large tumor size. And each of these clinical pathological factors is associated with a high risk of recurrence in the first few years. There was a second cohort that looked at the addition of Ki-67 in those who had otherwise lower risk features. So 1 to 3 nodes, it wasn't a large tumor, it wasn't grade 3. So the 2 centimeter grade 2 tumor with 1 node involved, but it had a high proliferation. This cohort came on later and is around about 10% of the population overall. But Ki-67 was measured in all of the tumors, and we'll look at those data shortly. So the trial had primary endpoint of invasive disease-free survival, with key important endpoints in the secondary setting at the invasive disease-free survival in the high Ki-67 cohort, as well as distant relapse-free survival and overall survival. It's also worth pointing out that all patients were staged at diagnosis and had to have negative CT and bone scans, because they're higher risk patients, but we wanted to make sure that they did not have early signs of metastatic disease. They were at risk of that because of the high risk features, but they were all stage negative. And patients were then stratified based on their prior chemotherapy, whether it was neoadjuvant, adjuvant, or none, and their menopausal status at diagnosis and the region that they were treated in. If you look here at the distribution, you can see the average age was 51. So we were treating a lot of younger patients. You can see here that 43% were premenopausal at diagnosis. And in terms of chemotherapy, 95% had received chemotherapy, so a higher percentage than in the PALLAS trial, and 37% were in the neoadjuvant setting. So these were younger patients with node-positive, larger tumors, many of whom had neoadjuvant chemotherapy. In terms of Ki-67, it was measured in a central laboratory in all of the cases, and we obtained samples in over 80% of those in the trial, and over half of those had high Ki-67 defined by a cutoff of 20%. And that's an internationally recognized cutoff in the St. Gallen guidelines when we designed the trial that identified those with higher risk proliferating disease. Now, the endpoint analysis of the study was measured at the interim analysis, which triggered the first disclosure last year, a primary outcome analysis when the primary endpoint was met at San Antonio last year, and then this additional follow-up that was triggered by an analysis in April of this year at the regulator's request, which allowed us to now look at the data with 27 months of follow-up and with 90% of the patients through and off the 2-year treatment period, which at the initial disclosure, there was only 12% of patients who had completed that initial 2 years. So we now have most of the patients through the adjuvant abemaciclib phase and significantly more follow-up. So if we look at the updated efficacy analysis, the Kaplan-Meier curves here show a very significant separation of the curves with a hazard ratio of 0.696, representing a 30% reduction in risk of developing an invasive disease-free event. We now have robust data to say at the 3-year point, the difference in IDFS has improved from 83.74% on endocrine therapy alone to 88% with the addition of a CDK inhibitor. That represents an improvement of 5.4%. It's worth pointing out here that the control arm is doing relatively poorly here, as we had predicted when we designed the trial, namely that at 3 years, nearly 17% had already developed a recurrence of their disease, set to be around, heading for the 80% IDFS at the 5-year point, which we designed the statistics around. Now, if you look at all the individual subgroups, there was no particular subgroup that seemed to be getting more or less benefit. So benefit was seen across all predisposed subgroups, and there was no statistical interaction. I always point out here that those younger patients, the premenopausal patients, as well as those who are on neoadjuvant therapy, the hazard ratios were around about 0.58 and 0.63. So these really younger, high-risk patients seem to be getting an enormous degree of benefit from the addition of the therapy at preventing that early evidence of recurrence. Now, this graph now shows the distant relapse-free survival, which is essentially metastatic sites of disease. It takes out the local recurrences or death from any cause. And you can see here that the absolute improvement in distant relapse-free survival was 4.2% at 3 years, again, representing a very significant reduction in risk of developing a metastatic event, with the curves separating early and appearing to continue to separate even when the patients have finished their 2 years of therapy. Now, the treatment effects over time were presented at the ESMO plenary in an exploratory analysis looking at the piece-wide hazard ratio in each of the first 3 years. And what you can see in both for invasive disease-free survival and distant relapse-free survival is that the hazard ratios appear to be getting stronger year on year. So it's going to be really important to continue to follow the trial to see if the curves continue to stay apart. But the early data at the 3-year point are very encouraging that this benefit is both robust and maintained. Now let's look at the Ki-67 high-risk group, which was measured, as I said, in over 80% of the patients, and over half of them had high Ki-67. And if you look in the intent to treat population for those with a high Ki-67, here the benefit appears to be even greater. You can see a 6% absolute difference at the 3-year point, improving from 80.8 to 86.8 with a hazard ratio of 0.63. And if you just look in cohort 1, who had high clinical risk features with Ki-67 layered on top as an additional risk factor, here you can see an impressive 7% gain from 79% with endocrine therapy alone to 86.1% with the addition of the CDK inhibitor abemaciclib. So a very significant gain in these higher risk patients who in this particular graph with endocrine therapy alone, nearly 20% have already relapsed within the first 3 years. And the addition of the CDK inhibitor has a big impact in that group. And this is the population that the FDA have given the approval in. Now, if you look at this particular combined graph, you can see that Ki-67 is an important prognostic factor, but not necessarily a predictive factor for abemaciclib gain. If you just look at the blue curves alone with endocrine therapy, you can see here the impact of Ki-67, and that with a high Ki-67, the 3-year relapse, 3-year survival rate was 79%, and it improved to, as you can see, nearly 90% in the low Ki-67. But if you look at the impact of abemaciclib, it was seen in both the high Ki-67, that's the solid group, as well as the low Ki-67, which is the dotted group. So there is benefit not only in terms of the addition of the CDK inhibitor to both groups, and therefore Ki-67 is really only acting as a prognostic factor for identifying those high-risk group, but it's not necessarily telling you who will or won't predict a benefit from the drug. Now, safety is always an important point when you're adding a new therapy in the adjuvant setting. And we know that the CDK inhibitors do add some additional toxicity. And in terms of abemaciclib, the most common toxicity is diarrhea, which is low grade in the vast majority of patients. Very few patients had to come off therapy due to the incidence of diarrhea, but dose reductions and dose holds were common as per the protocol. So 42% had a dose reduction, 59% had a dose hold, and the adverse events normally settle within the first 2 to 3 months. Fatigue and neutropenia were the other most common side effects, but the incidence of neutropenia is far less than with the other CDK inhibitors, which produce reversible neutropenia and require a 3-week on, 1 week off schedule. There are some other adverse events of special interest that we need to be aware of. There is a low incidence of venothrombotic events, more common probably if tamoxifen is the partner of choice. And there's a low incidence of interstitial lung disease that, again, we're aware of in advanced disease, but is important to make patients aware of if they have any change in respiratory symptoms and need intervention. So to conclude, the Monarch E trial is the first study to show that the addition of a CDK inhibitor improves invasive disease-free survival and distant relapse-free survival, and it improves it beyond the 2-year treatment period. The safety data are fairly mature now, so we have a good indication of how to handle the drug and to know how the side effects are and how to manage them. And the data on Ki-67 are important because it's a clear prognostic factor in identifying patients who are going to do worse on endocrine therapy, but not necessarily a predictive factor for abemaciclib because it can be seen in both the high and the low risk groups that the drug can provide benefit. Now, the full data are published now in the Annals of Oncology at the same time that Joyce presented them at the ESMO plenary. And 2 days before, the FDA gave approval for abemaciclib in high-risk early positive breast cancer, but included the addition of Ki-67 as a marker of that increased risk on top of the clinical and pathological features that were eligible for the trial.
On November 15th, the American Society of Clinical Oncology published a rapid recommendation update to their guidelines for optimal selection of adjuvant chemotherapy and targeted therapy for early breast cancer. The update focuses on the use of adjuvant abemaciclib with endocrine therapy as treatment of patients with high-risk disease and expands on the recent FDA-approved indication by recommending that all patients who meet the eligibility criteria of Monarch E should receive adjuvant therapy with CDK4 and 6 inhibitor therapy plus endocrine therapy. Specifically, the guideline update states the following recommendations from the ASCO panel. Based on a secondary predefined analysis conducted by the FDA, 2 years of abemaciclib administered at a dose of 150 milligrams twice daily plus endocrine therapy may be offered to patients with hormone receptor-positive HER2-negative node-positive early breast cancer with a high risk of recurrence and a Ki-67 score of greater than or equal to 20% as determined by an FDA-approved test. Furthermore, the panel also recommends, based on analyses reported by Harbeck and colleagues in the Annals of Oncology publication, that abemaciclib for 2 years plus endocrine therapy for 5 years or more may be offered to the broader intent-to-treat population of patients with resected hormone receptor-positive, HER2-negative, node-positive early breast cancer at high risk of recurrence, defined as having more than 4 positive axillary lymph nodes or as having 1 to 3 positive axillary lymph nodes and 1 or more of the following features: histologic grade 3 disease, tumor size greater than 5 centimeters, or Ki-67 index greater than 20%. Qualifying statements accompanying the update noted that although exploratory analyses suggested similar hazard ratios in favor of abemaciclib regardless of Ki-67 status, there were relatively few Ki-67 low tumors in Monarch E. In addition, when discussing treatment options with patients, the potential benefits should be weighed against the potential harms.
So 2 or 3 other slides to finish up now, really about putting these data into context and where we are going with other research in this area. Joyce mentioned the PENELOPE-B trial, which was a study of patients who had neoadjuvant chemotherapy and then selecting patients who were still at risk because they had residual disease, which is common in luminal breast cancer. They were randomized to either palbociclib or placebo for only a year of treatment, Overall, the trial was negative, but there was that interesting early separation of the curves that then subsequently came together. Now, in the discussion of the ESMO plenary talk, Ati Abadia gave a very thoughtful discussion and comparison of the trials, and this is one of his slides that he's kindly lent to me, which really looked at the 3 studies head-to-head and compared the impact and the benefit that we've seen. The 2 palbociclib trials are negative, as we've just looked at. The PALLAS trial had around about 23 months of follow-up. The PENELOPE-B trial had much more follow-up of over 40 months. The discontinuations were high in the PALLAS trial, which might have meant that patients were not exposed to the drug, but that was not seen to the same extent in the PENELOPE-B trial, and that trial was negative. The Monarch E trial has clearly identified that there is a significant reduction in risk of recurrence with a hazard ratio of 0.69, which is markedly different to the other 2 trials. Now, why were these studies different? We could argue that Monarch E got the correct population, the higher risk population. But even in the PALLAS trial, where they looked at the higher risk patients who were 60%, they saw no benefit there. We've talked about the discontinuations, and it's possible that that was a problem in the PALLAS trial, and that you need to stay on drug to be able to get the benefit. And that's about appropriate management of the adverse events and the toxicities. But ultimately, it may come down to differences in the drugs, because the key difference here is that abemaciclib is a continually dosed drug, whereas the CDK inhibitor palbociclib is intermittently dosed, 3 weeks on, 1 week off. And in the setting of micrometastatic disease, that difference might be crucial in the ability of eliminating microscopic metastatic disease rather than allowing it to remain relatively dormant and persist. This is a hypothesis which we'll need evaluating, but it's increasingly what people are thinking about that might explain the differences. We also know that abemaciclib appears to be better at treating endocrine resistance. When we compare the data from PALOMA-3 and Monarch-2, we got much better efficacy with abemaciclib in treating those with primary endocrine resistance. And abemaciclib also has good single agent activity. So the drug may have a number of other features that mean that it is particularly effective and potent in the adjuvant setting. And the molecular differences also pertain to its different kinome inhibition, with a much greater kinome inhibition of CDK4/6, and also perhaps some indirect impact on cyclin D2 as well, which might have an impact on other aspects of the cell cycle that could be escape mechanisms for palbociclib. Research is ongoing, and there is another important trial called NATALEE that's looking at the role of ribociclib at a lower dose for 3 years of treatment. That trial is recruited, and we need to see and look at the results of that trial. And ultimately, the other way that we're looking at it is using Ki-67 to identify the high-risk patients up front. We've shown you data about the static Ki-67 in terms of those who are at greater risk of recurrence, but there's also the role of a dynamic Ki-67 that Joyce mentioned, where you give short-term exposure of an aromatase inhibitor and look for the change in Ki-67. And that was first assessed in the POETIC trial in the UK, where in 4,500 patients, we looked at the role of short-term Ki-67. And what you could see is if the Ki-67 was either low at the outset or was high and dropped down low with the impact of the drug, the patients seemed to do quite well in green and blue here. But if they had high Ki-67, which did not drop with the short-term exposure, then they had an increased risk of recurrence, which was up to 20% in the first 5 years. And that's a very similar percentage to those in the Monarch E trial who had high-risk clinical features. So you could use a model of primary endocrine resistance here, looking at short-term exposure to letrozole to identify those who are not necessarily going to respond to their endocrine treatment. And we're now addressing that in the POETIC-A trial in the UK, where we're using that to identify and enrich a population of endocrine resistance and then randomize them to the addition of abemaciclib or not, to see if that impact of endocrine resistance in smaller tumors, those not necessarily with nodes involved, but inherently endocrine resistant at the outset, whether we can derive benefit in that setting. Our colleagues in Germany are doing a very similar combination study in the ADAPT cycle, where they're looking at changes in Ki-67 and integrating it with the Oncotype recurrence score. So I think you'll see more research going on to use genomic features, dynamic features to identify endocrine resistance and identify those patients who perhaps have smaller node-negative disease where these therapies could have a role to play. So thank you for that. And I hope that that has provided an understanding of the recent data and the benefit that a CDK inhibitor such as abemaciclib can add in these higher risk patients.
Wonderful discussion. Thank you so much, Stephen. Fabulous data. And thanks for putting it into the context, too, of other trials that have gone on in the adjuvant setting with the CDK4/6 inhibitors. And I did want to mention again that you'll be able to download and use additional resources, a practice aid focused on adjuvant treatment selection regarding the Ki-67, which is an important part of the FDA approval for adjuvant abemaciclib. We might have a little discussion about that here now. And so now it's my pleasure to talk to Stephen and Judy about some cases that we want to apply these data that Stephen have just reviewed to high-risk breast cancer patients. So I'd like to turn us over to Judy, who's going to go ahead and present some cases for us for have some discussion.
Excellent. So we're going to start off with hopefully a more straightforward case. This is a 53-year-old woman who presents to your clinic. She has a palpable 4-centimeter breast mass and enlarged ipsilateral axillary lymph nodes. Biopsy shows a grade 3 invasive ductal carcinoma, and her fine needle aspiration of her ipsilateral axillary lymph node is positive. She is treated with preoperative chemotherapy with dose-dense ACT chemotherapy and then proceeds to surgery. Pathology from surgery shows residual disease with no significant treatment effect seen. She's got 4 centimeters of residual grade 3 invasive ductal carcinoma, and 4 out of her 11 lymph nodes from axillary dissection are positive. And the Ki-67 on this tumor was 40%. What would you recommend as adjuvant therapy for this patient? And multiple choice options here: ovarian suppression with AI, ovarian suppression plus AI plus abemaciclib, ovarian suppression plus tamoxifen plus abemaciclib, ovarian suppression plus tamoxifen, or tamoxifen alone. Joyce, how would you approach this patient?
Well, she is certainly very high risk, and I'm assuming she is premenopausal because ovarian function suppression is listed as an option for several of the choices that we have here. Well, she's a perfect candidate for adjuvant abemaciclib. She would have been eligible for the Monarch E clinical trial. She has 4 or more nodes, and that's one of the eligibilities. She does not have T3 disease, but she does have the 4 or more nodes, and she does have the Ki-67 more than 40%, in spite of the fact that she received preoperative chemotherapy. A lot of times patients will have a suppression of Ki-67. The chemotherapy will kill off the proliferating cells, and you'll be left with the cells that are more endocrine therapy sensitive and a lower Ki-67. But this patient looks like she has some primary resistance to chemotherapy, a really poor prognosis. So I would optimize her endocrine therapy with ovarian function suppression and aromatase inhibitor, and clearly would talk to her about the 2 years of abemaciclib. I think she's ideal. And I want to just ask, Stephen, a lot of people don't get the Ki-67 routinely as part of their standard pathology report. What should we do now? Should we go back to the pathologist and ask for it? Can it be done locally? Does it need to be done centrally?
Well, I think part of the controversy about Ki-67 is exactly what you've just pointed out there about the actual methodologies and the scoring systems. And attempts have been made to standardize these now in terms of not only the assays and kits that are used, but also the subsequent scoring system. I think everybody's been very comfortable with really what's a very low Ki-67, 5%, and what's a very high Ki-67, as in this case here, of 40%. The challenge has always been around about the cutoff. In the trial, we did it centrally to remove all of that. But somebody else's 16% might be 23% in another lab, and that's where I think with this FDA approval of it based on this cutoff, using the diagnostic kit that has been recommended, will be important to try and standardize the methodology for measuring it and then the subsequent scoring system. I think in this particular case, however, it's barn door that this was a highly proliferating tumor that was pretty resistant to chemotherapy. I think locally, clinicians are going to have discussions with their pathologists about measuring this more frequently. Many centers do it routinely in their breast cancer practice, many do not. But I think we're now going to find now with an approval based on it that it's going to become much more mainstream that it's being done. But there are guidelines to try and standardize how it's measured, done, and scored.
Let me just ask Stephen and Joyce, the Ki-67 measurement we usually do on the baseline tumor prior to chemotherapy. In some cases, it's repeated post-chemotherapy. Which of those numbers would you be utilizing at this point to assist this patient in considering her treatment option?
No, I mean, in the trial, we did it all on the baseline. So it was the baseline level. In this particular patient, whether it's baseline, it's still high now. So that's an indication that this is a proliferating tumor resistant to the therapy. I think if you're going to use a short-term exposure of endocrine therapy, then you need to know whether it's before or after. But in this particular patient, I don't think you need to measure it in any other tissue. It's probably high to start with as well.
And I would just say that if she was 40% to start off with, and it was repeated after chemotherapy, and she was down to 10 or 15%, I would still recommend abemaciclib for her based on her baseline Ki-67, because that's what was done in the Monarch E clinical trial. You know, so we want to go by what the trial did so we can get the results of the clinical trial. And I just want to mention in the US that the FDA has that companion diagnostic that Stephen just mentioned, and those kits can be ordered from Agilent. It's a DACO test that's done on their Omnis machine. And it's very, very automated with all the positive and negative controls. And then reading the slide is quite standardized. You know, the whole slide is looked at, and the percentage of cells with at least 1+, you know, definitive staining of the nuclei with the brown stain for Ki-67, those cells are counted. The Ki-67 positive nuclei divided by the, you know, a semi-quantitative number of the entire tumor cells on the slide, and that's your percentage. And it has to include all the hot spots. So it's a pretty standard methodology of counting. And again, as Stephen said, this is all now part of the FDA companion diagnostic, or many reference laboratories are set up to go. For example, I know for sure Quest is currently set up to go, but there'll be many others coming online. Central reference laboratories will be able to do this according to the FDA companion diagnostic. So it's really very readily accessible right now. Great. Well, let's go on to the next case there, Judy.
Okay, it's a little bit more complicated one. 56-year-old lady who presents with a newly diagnosed breast cancer. It's biopsied and proven to be an invasive ductal carcinoma. This tumor is a grade 2 tumor. ER is 81 to 90%, PR 31 to 40%, HER2 1+, and her Ki-67 is 25%. Her mass measures 2.9 centimeters on her ultrasound and her MRI. Palpation of her axilla does not reveal any palpable adenopathy, and ultrasound shows no abnormal appearing lymph nodes. She proceeds with surgical resection first, and she's interested in breast conserving surgery. So she goes to the operating room and undergoes a lumpectomy and sentinel lymph node surgery. The final pathology shows a 3.2 centimeter grade 2 invasive ductal carcinoma resected with negative margins. She has 2 of 3 sentinel lymph nodes positive. One of them has a 4 millimeter metastasis. One of them has a 1 millimeter metastasis. And since this patient meets the ACOSOG Z11 criteria, the surgeon elects not to proceed with any further axillary surgery. So she's proceeding with axillary preservation given her meeting the Z11 criteria. So the question really here in my mind is, how does this now impact, positively or negatively impact, her opportunity for consideration for abemaciclib? When you put this patient scenario into the Memorial Sloan Kettering nomogram to predict her likelihood of additional positive nodes, she has about a 36% chance that if she went back to the operating room for an axillary dissection, that we would find additional nodes and prove that she has more than 2 positive axillary nodes. However, her current management would be not to proceed with an axillary lymph node dissection. So as a surgical oncologist, Joyce and Stephen, I find this very challenging. Does this mean that we should now be performing axillary lymph node dissections in these patients in order to prove that this patient may have 4 or more positive lymph nodes in order to have her have the potential to benefit from abemaciclib? Or how would you treat this patient knowing that she has documented 2 positive nodes and about a 36% chance of having 3 or more positive nodes?
Stephen, what do you think? This is really challenging.
Yeah, I mean, this patient falls in the trial into what we call cohort 2, where essentially they have, grade 2 cancer, 1 to 3 nodes. It's not a large tumor. And the only risk factor is the high Ki-67. But unlike the previous case, it's not 40 or 50%, it's a 25%. So this is really borderline, I think, in terms of, they got into the cohort 2. We haven't analyzed cohort 2 separately on its own yet because there aren't enough events in that particular cohort, and it will take further follow-up to look at that. So your question, Judy, is really, would you go hunting for more nodes, given that there's a 36% chance just to get them into the approval for the addition of the drug, which would get them into what we call cohort 1. And that's a tricky one. I mean, clearly the issue is what further management of the axilla is needed. If surgery wasn't undertaken, would you be including the axilla within the radiation field to manage and reduce that risk? Because regardless of whether you have another drug, the issue is how the axilla is going to be managed from that point of view. But I think this is deliberately chosen as a tricky case because it is just that. And I think you could argue the case either way in terms of further surgery or not, just to see. I don't know, what do you think, Joyce?
You know, this has been a big issue of discussion here in the States with the FDA approval of the cohort 1 plus the addition of the high Ki-67, which this patient does have. And clearly the FDA's intent here was to really single out at this early time point the highest risk patients, because as you showed, Stephen, there was over a 7% absolute benefit in invasive disease-free survival at 3 years in this group that was FDA approved. That's a huge impact. And so that's what the FDA said. Let's pick the highest risk population, and then we'll follow the patients a little longer. And then we all expect that the entire intent to treat population will eventually be on the label. But as you pointed out, the intent to treat population is strikingly positive as well. And so I think this is the kind of situation we're going to have to sit down and talk to the patient, really think through the patient's overall risk. I think that going back and doing additional axillary surgery for this express purpose of trying to find more nodes to justify the use of abemaciclib, I don't think we should be doing that. I think that our axilla will be well taken care of with, regional radiation of lymphatics, which is standard of care. And so this is something that I would talk to this patient about abemaciclib. It's high risk. It's high Ki-67. She's got 2 nodes. One's a macrometastasis. It's a big enough cancer, et cetera. And the intent to treat population is positive. So I think that rather than ask somebody to go back to surgery, I think this is one of those things where there's going to need to be a little flexibility, honestly.
Well, that's very good news. I'm glad that we won't necessarily be taking a step backwards in terms of the surgical de-escalation. And there can be much debate about the local regional management of this case. Obviously, with Z11, they did not do radiation directed to the axilla. Amaro's trial obviously looked more at definitive nodal radiation, but we'll leave that for another debate. So our next case is similarly a 73-year-old lady. She presents with a 1.9 centimeter tumor. It's grade 3, invasive ductal, ER 81 to 90%, PR 81 to 90%, HER2 1+. Ki-67 in this case is 32%. She's healthy, she's active, she really has nothing in terms of comorbidities. Her axillary ultrasound is negative for axillary adenopathy, and she elects breast conservation. She proceeds to surgery and undergoes a wide local excision, and pathology shows a 2.4 centimeter grade 3 invasive ductal carcinoma resected with negative margins. Now, importantly, following the Society of Surgical Oncology Choosing Wisely guidelines, she did not undergo any surgical staging of her axilla. So her clinical staging was negative by physical exam and ultrasound, but she has not undergone surgical staging of her axilla. So she's got a grade 3 tumor. Thoughts on the management of this case in terms of the absence of surgical staging? Her likelihood of nodal positivity with a grade 3 tumor is probably somewhere around about 30% with a 2.4 tumor on final pathology. And is this really driving us to an area where we need to be having more multidisciplinary discussion in the preoperative setting?
Well, this is really very interesting because clearly node negative patients were not included in the Monarch E, even in the intent to treat population. And, there is a, difference between node negative and certainly node positive in terms of outcome. However, one could argue that is there a huge difference between node negative and even just one node positive, for example, but 1 to 3 nodes positive, since she has a grade 3 cancer and she does have a Ki-67 of 32%. If we even knew she had 1 lymph node positive, she would be eligible for the Monarch E. And I would talk to her about abemaciclib. And I really am so glad that she did have the axillary ultrasound looking for a lymph node, because even if she had a fine needle aspiration of a lymph node and it was positive, that would be, adequate reason. Of course, you probably would go ahead and have that removed, of course, clipped and removed. But, I'm finding myself here thinking that I would like to know that she had a lymph node positive, because if she did have a sentinel lymph node biopsy and she was node negative, I would not recommend the adjuvant abemaciclib to her. She's not quite high enough risk in my mind at this time, in the absence of knowing she's lymph node positive, to offer her abemaciclib. So I'd probably lean against it. But I think the surgical question here, the last, is discussion needed to avoid the axillary surgery? I'd probably say yes at this point. Stephen, what do you think?
Yeah, I think this is the case where, at face value here, this patient wouldn't be considered for abemaciclib because they are radiologically and clinically node negative. You say, yes, they may have a 30% chance, but if auxiliary surgery isn't going ahead, then we wouldn't be able to sort of, recommend the drug based on the trial criteria. Having said that, and this is the group of patients I alluded to in the further research we're doing now, I don't think the role of CDK inhibitors here is limited to those with large tumors and large nodal burden. It's inherent in the tumors that are biologically more endocrine resistant. And the clues here are not only in the grade, but also in that Ki67 of 30%. Now, the PR is 90%. If the PR had been a lot lower in the ER, I'd be really thinking that this is, a luminal B tumor that's really got an increased risk of recurrence if we just rely on endocrine therapy alone. We're presumably not going down the route of chemotherapy here, although again, there could be debate in a tumor board here about the biology of this cancer as to whether that was actually going to then be sent off for a recurrence score. And as we know from Taylor-X in the node negative, or R-Exponder in the 1 to 3 node positives in the postmenopausal, it's really only those with a high recurrence score where they would be targeted for more adjuvant drugs with chemo. And chemo may not actually be the answer. It may be actually better drugs to modulate endocrine resistance, which is what abemaciclib is all about. So I think more research to understand these anatomically lower risk patients. Coming back to her and the management of the axilla, it's a real challenge. And I think I wouldn't necessarily be pushing it anymore, because I think our standard of care here has been pretty good. But I think this is the next unmet need, where the clues are in the tumor biology that they're at increased risk, but the clues aren't necessarily in the anatomical pathological features that would indicate all the time that they need this particular treatment based on node status. So I'm not sure I would take her back for more surgery, but I certainly talked to her about it. I don't know what you did, Judy, or what you would have recommended here.
Well, what I'm thinking really is I've been a big adopter of the Society of Surgical Oncology's Choosing Wisely guidelines and trying to de-escalate axillary staging for those women over 70 with hormone receptor positive disease. But I think with the Monarch E study and with the FDA approval, my thought is, for those people that are at the lower end, that 70 to 75 or even 70 to 80, if they have a grade 3 tumor, it's probably going to be worthwhile a quick call to my medical oncologist. Maybe it doesn't need to be a formal consult, but an e-tumor board discussion or just a whole side discussion with my medical oncology colleagues to say, is this a case where we think sentinel lymph node surgery at the time of her lumpectomy should be performed? I think for the women over 80 and the grade 1 and the grade 2, it's probably a little bit less controversial. But I think for the grade 3, younger portion of the over 70, I might be calling my medical oncology colleagues a little bit more frequently over the upcoming year.
Because the answer may not necessarily be chemotherapy here, which is, we've seen even in the patients who've been giving chemotherapy, if they've got the inherent endocrine resistant features, that's not going to solve their problem.
Yeah, no, I mean, just calling them to say, would a sentinel node biopsy be advantageous, and avoiding following the guidelines.
Yeah. Totally agree. Yeah, totally agree with everything. Yeah, excellent. Really good. These are great cases.
Okay, and then I think last case takes a slightly different look at the situation. So we have a 51-year-old female. She has a 4.9 centimeters, so just shy of our T3 cutoff, left breast cancer. It is invasive ductal. It's grade 2. ER is 71 to 80%. Here, Stephen, you get your lower PR of 1 to 10%. HER2 1+, and her Ki-67 is 62%. She has no palpable axillary lymph nodes, but axillary ultrasound does identify 3 abnormal appearing lymph nodes with cortical thickening. She undergoes an axillary ultrasound guided percutaneous biopsy that's positive for metastatic adenocarcinoma and has a clip placed in her lymph node. She does proceed with treatment with neoadjuvant chemotherapy. She receives 4 cycles of AC and 12 cycles of T. She has a partial clinical and a partial imaging response. Her mass decreases from 4.9 down to about 2.6 centimeters on ultrasound. Her axillary lymph nodes normalize, and the surgical plan in this patient is for a lumpectomy, along with seed-localized sentinel lymph node surgery, or what's been coined as a targeted axillary dissection. And you discussed with her preoperatively that the standard of care would be in the setting of a positive sentinel node, that she would proceed on to axillary dissection, but she's extremely worried about lymphedema and actually declines a completion axillary lymph node dissection in the event her lymph node is positive. So her pathology from her surgery post-chemotherapy shows a 2.8 centimeter invasive ductal grade 3 with 1 of 3 lymph nodes positive, which was the clipped node. So clinically, she had 3 abnormal nodes to start with. Post-chemo, she has 1 positive node on pathology with a grade 3 tumor with a partial response. So is this patient a candidate for consideration for abemaciclib, or does she require an axillary dissection really to prove that she has these 4 or more positive nodes?
Oh, I think she is an excellent candidate for abemaciclib, really just on the risk features that she already has without additional axillary surgery. I think we're going to have to be a little bit more flexible. This patient will receive radiation therapy. She'll be at high risk for lymphedema, and she, something to be avoided if at all possible. So she's very high risk, almost a T3, very, very high Ki-67, 3 positive nodes that were probably macro metastasis to start off with. So I'd be very comfortable and be very enthusiastic about offering her abemaciclib.
Yeah, I mean, I think she would get into the trial based on the fact that it was grade 3 ultimately, because remember, your core at presentation may not have the full picture of what the cancer was like, but the clue, because the discrepancy there is saying grade 2 but a high Ki-67 of 62%. How many times is, when you've actually done the full pathology analysis, is it really a grade 3 cancer? And so with 1 to 3 nodes and one of the other features, which was either high grade tumor size, which it pretty much almost was, and high Ki-67, this would be would have fit the criteria for the trial, and therefore is at increased risk of recurrence. We know that neoadjuvant chemotherapy in luminal breast cancers may downstage, but doesn't actually produce high path CRs at all. And those patients are still got a 20 to 30% risk of recurrence in the first 5 years. So I would have thought she would be an absolutely excellent candidate for abemaciclib.
So the grade 3 on the final pathology put her into meeting the trial criteria. But if she would have been grade 2 on the final pathology, it sounds like both of you are significantly enough concerned about this patient from a standpoint of tumor biology. You would want to try to offer her abemaciclib, even if she doesn't completely meet the criteria for Monarch E, or if that final path came back grade 2 rather than grade 3, would we still be able to treat her?
And the original grade was grade 3. Was that right, Judy?
2, grade 2 originally.
Grade 2. So grade 2, both places. But the Ki-67 of 62%, I think I'd repeat it. It was very high again. I certainly would treat her with the abemaciclib. If it came back, even in spite of preoperative therapy, she still has very high Ki-67. I would, there is a little bit, there's certainly inter-observer variability on grade. There's the high end of grade 2, which basically could be the low end of grade 3, et cetera. So that is a little bit subjective. So I'd look at the fact this is not a high ER, this is not a high PR, and with this high Ki-67, I think she is going to likely be primary endocrine therapy resistant. So I am very worried about this patient. Truthfully, I just want to ask this next question. What if she declined neoadjuvant chemotherapy, but she's got a T3 cancer and she does not want chemotherapy, but she does need some cytoreduction clinically? And Stephen, is there a role for neoadjuvant endocrine and abemaciclib?
Short answer is at the moment, no, I don't think so. I mean, because what we've seen with the Monarch and the palette trial is we'll have a greater anti-proliferative effect, but we won't produce significantly higher radiological response rates or pass CR rates. So you'd have to treat for a long time. I mean, if the patient with a T3 and you were going to treat with, endocrine based or endocrine plus, which is with a CDK inhibitor, in the trials, it was 14 weeks. It's probably not long enough to actually get proper downstaging if she was keen to avoid, subsequently a mastectomy for that reason. But it's not an indication that I would use at the moment. The only indication is really if it's locally advanced disease and it's technically inoperable, then the drugs are licensed within the setting of locally advanced or metastatic disease. But again, you treat for a much, much longer period of time. I think it also just highlights that these criteria are never black and white. And that's why I think, Judy, you've chosen these specific examples, because they are on the cusp. And these things in medicine are a continuum. And as Joyce says, I think you get a flavor for what's the cancer that you're dealing with here. And the criteria had to be set within the trial for a certain limit. And it's a question of how that's going to be managed. But we're going to have all of these cases on a regular basis and lots of discussion. But inherently, it's about what you feel the biology of this cancer is and what this inherent patient's risk of recurrence is. And as I said before, chemotherapy here is not the answer. And good surgical and local regional management is very important. But optimal adjuvant endocrine therapy is really what we're talking about here. And I would certainly be having a discussion here because all the features are of high risk.
Yeah, totally agree. I just want to mention, I totally agree with Stephen, that the patient's operable, even if she's a T3 cancer, it's best for her to go to surgery if she declines the preoperative chemotherapy that we might otherwise give her for high risk biology. There will be patients, as Stephen said, that are inoperable and really do need cytoreduction before they can go to surgery if they decline or otherwise not a good candidate for chemotherapy. I think what will end up happening, particularly in those who have features that suggest primary endocrine therapy resistance, is that we will give some preoperative abemaciclib and endocrine therapy until we get excellent cytoreduction, stop briefly to allow the patient to go to surgery, and then finish out her 2 years of adjuvant abemaciclib and endocrine therapy, along with radiation therapy. And so I think that in the Monarch E, radiation and abemaciclib were not given together. So I think the patient would need an interruption in the abemaciclib to get the radiation therapy. But I think we will be using some preoperatively in select patients where we need cytoreduction, but we don't have otherwise good strategies for it. I just wanted to mention with regard to the audience Q&A that's already come in. Fortunately, I think we've really covered, essentially all of these questions. And just there was a question here, Stephen, is there a correlation between side effects of abemaciclib and efficacy of abemaciclib?
Not that we're aware of. I think the key thing is, and the key practice to tell everybody is about you find the dose that's right for the patient. What there clearly is the efficacy will be just as good depending on what dose you find out. The side effects really determine the dose that you need to treat the patient with, but the dose, regardless which dose you're on, the efficacy appears to be the same. So you use the toxicity to find the right dose, and then it's not a dose response in relation to the dose that you're on in terms of efficacy.
Thank you. Thanks so much. And thank you, Judy and Stephen. This has really been informative. I hadn't thought about all these clinical scenarios because the FDA approval is so new. We've just had this so recently, but it's really helpful to think about how to apply these very important new data to our practice. So thanks so much. It's been a pleasure working with you. And I want to just, for our participants, please remember to complete and submit your post-test and evaluation for credit. And please visit at peerview.com and download the slides and the practice aids. The additional information about Key 67 is there. And please join the conversation on Twitter. And I thank you so much for your participation.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/HYM860. This activity is supported by an educational grant from Lilly.